So next video is breast cancer and pregnancy. How would you assess a breast lump in a pregnant woman? So same triple assessment history, also must be assessed with the core biopsy and FNAC. If required, staging formats can be undertaken with chest X-ray, liver ultrasound, CT and bone scans are not recommended due to radiation exposure to fetus, and gadolinium and MRI is not recommended. What are the factors to consider in women with confirmed breast cancer in the various trimester of pregnancy? So first trimester is the option. Either we should terminate the pregnancy or first ensure the correct dates, then do choriovilus sampling, maybe perform tender amniocentesis at 15. This is the most risky period for the fetus. Increase miscarriage rates even without treatment. The option of termination pregnancy should be discussed with the patient. And discussion of cancer prognosis and treatment. The effect of treatment and fertility should be discussed, and referral to the fertility specialist and counseling should be available. The fetus is most vulnerable to the effects of radiation. Avoid bone scan. Chest fetal shielding is acceptable. Chemotherapy is associated with 20% risk of miscarriage in this trimester and 10 to 20% risk of malformation. Second trimester is still an option, but the fetus is now less vulnerable. Fetal part ultrasounds can be conducted at 16 weeks. Surgery may be performed in this trimester. Chemotherapy is associated with intrauterine growth retardation and decreased birth weight, but is overall consistent and safe if oncologically required. Anthracyclines are considered safe. Third trimester, decisions are less difficult. Surgery is safer. Chemotherapy may be administered as appropriate. Treatment in some can be delayed until after birth. Consider expediting delivery to around 34 weeks. What are the issues surrounding surgery in the pregnant woman? Breast and axillary surgery can be undertaken in all trimesters. The anesthetic risk to fetus declines throughout the duration of pregnancy. This requires close collaboration with the obstetrician throughout the management. Breast cancer surgery versus mastectomy. This is the same decision-making process as for any other breast cancer. Sentinel node biopsy, blue dye not recommended. Technetium and non-fetal dose very small, 4 milligray, but full effect unknown. Consider 4-node sampling. Breast reconstruction can be delayed. Avoid prolonged anesthesia. Reduces recovery time. What are the outcome of pregnancy with breast cancer? The patient, the 5-10 years recurrence rates are the same as age-matched controls. Fetus first trimester with termination rates increase. Congenital malformations and reduced birth weight are associated with the chemotherapy use. Contraceptive choices for breast cancer treatment. Hormonal contraception is contraindicated in women with current recent breast cancer. Options for preserving fertility. Ovarian function can be preserved with Zoladex, which puts the ovary to sleep before chemotherapy. And the management of pregnancies after previous breast cancer treatment. Tamoxifen should be stopped 3 months prior to conceiving, and risk of cancer recurrence is high in the first 2 years, so always advise to the patient, don't conceive for the first 2 years. What are the issues surrounding systemic treatment and radiotherapy pregnancy with the breast cancer? Again, they have mentioned the different effects of different chemotherapy on the pregnancy. Thank you.